Good afternoon, everyone. It's a moment of great honor and privilege for me to extend a hearty welcome to all of you today to the Lower GI Live webinar organized by APELS, Asia Pacific Endo-Lap Surgery Group. So far, we received 344 registrations to this Zoom webinar from doctors and nurses and medical professionals. As a medical academic group, APELS pushes the frontier in the field of endoscopic laparoscopic surgery in the past 7 years, providing a platform for the professional of this field all over the world to share the up-to-date information and innovative ideas through physical training workshop and virtual events. This webinar capitalizes our strength and realizes our commitment to the endo-lab professionals to cultivate an intensive learning culture and enhance professional competency in the endo-laparoscopic surgery to meet the ever-challenging in today's clinical care. Before we carry on the event, I would give my regards and appreciation to the hosts of this webinar, Professor Lee Suk-Hwan and Dr. Joe Fan, who has been putting extremely great effort to organize a high standard and interactive webinar. The 3 hours webinar will be put into 2 key parts. First half of the event, we capture the essence of APEL's legendary workshop with the presence of some very notable speakers from the region. Professor Lee Suk-Hwan from Korea, Professor Joel Lara from Vietnam, Dr. Supakij Khomvilai from Thailand, and Professor William Chen from Taiwan to share their insights, best practices on lower GI surgery complication and management, and combine endo-laparoscopic approach. Dr. Fan is our moderator today to lead us through the learning session. In the second half of the webinar, troubleshooting with expert session, we have difficult cases from 4 young energetic surgeons, Dr. Praveen Navendran from Australia, Dr. Supratim Bhattacharya from India, Dr. Yung Hon Bee from Korea, and Dr. Jian Wan Liu from China, sharing the learning experience in difficult case they encountered. With the panel, Professor Craig Lynch from Australia, Professor Simon Ng from Hong Kong, Dr. Lai Zhongxiang from Singapore, and Professor William Chen from Taiwan, and discuss the approaches. As a chairman of APELS, I look forward to the rapid growth of the society and wholeheartedly commitment to educate, train, and innovate in every aspect of the endo-laparoscopic surgery. Once again, I welcome you all and sincerely hope that you enjoy the program. I hope this webinar training program enlightens and provide us with practical approaches to deal with everyday challenges in our work field. Thank you very much.
Thank you, Professor Lee, for your kind introduction and welcome address. And as you mentioned that we are group focused on minimally invasive and endo-lap approach. So through this webinar, we hope that we learn from our experts, but also we'd like to our trainees or junior surgeons to share the experience and the difficulties to us so that we can all learn together. And without further ado, I would like to start the session on the lectures. Firstly, by Professor Suk-Hwan Lee. Suk-Hwan Lee is my best friend in Korea, and currently he's a Professor of Surgery in the Department of Surgery of Kwanghi University, Korea, and also Chairman of Korean Society of Endo-Laparoscopic Surgery. And today's presentation will be on emergency laparoscopic surgery with some video, because I find it more interesting and we can learn from experts through a multimedia approach. Firstly, are you ready? Hello, Professor Lee. You have to unmute your mic. Your microphone is not functioning yet. Maybe Kadora, can you help him to unmute the mic? Professor, we can't hear you for the time being.
My friend Lee, you have to open your microphone. You have to activate it.
A host can unmute Professor Lee's microphone.
Okay, good.
Yeah, it's working now.
Sorry. I'm very sorry. My computer does not work properly. So can you hear me?
Yes, sure.
Okay, thank you very much for the invitation. I have some technical problem with my mouse and the computer, so I'd like to share my slide.
Yes, we can see your slides very clearly now.
Okay. Can you see my slide right now?
Yes, sure.
Okay. Today good afternoon, ladies and gentlemen, Mr. Chairman, Professor Michael Lee and colleagues. I'm Suk-Hwan Lee from Kyunghee University Hospital at Gangdong, Seoul, South Korea. Today, I'm going to talk about the emergency laparoscopic surgery with some video presentation. I have no disclosure. The subtitle of my talk today is to do Hartmann's operation or not to do, or to do primary anastomosis. That is the question in left side colon cancer, colon population. Actually, for the high level of evidence, we need randomized controlled trial, but it is really difficult to enroll the patient with calculated sample size because the situation is the life-threatening illness. So far, we can find 5 randomized clinical trials comparing the treatment result from Hartmann's operation versus primary anastomosis for the left side colonic population. Especially in diverticulitis patient. We don't have much data about the colon cancer. So all the patients staged with a Hinckley stage 3 or 4 patients were enrolled as shown in this slide. So far we have 5 randomized trials. Most of the trials, they closed earlier and then they expected. So they do not meet the actual sample size to do the randomized trial because of the low, difficult to enroll the patient and very long period of the study. So from the RADIS trial published in 2019, actually primary anastomosis does not mean just primary anastomosis. So 78% of the primary anastomosis group had diverting ileostomy after the anastomosis. In this trial, 12 months stoma-free survival for primary anastomosis was 94.6% versus 71.7% for the Hartmann ratio. Hartmann procedures. So the hazard ratio is about 2.79. Based on the meta-analysis recently published, there is no differences in morbidity and mortality of both procedures. However, from the observational retrospective surgery, many papers reported better outcome for the primary anastomosis. However, that patient, that paper, that report are biased because the better surgical risk patient performed the primary anastomosis and poor surgical risk patient got Hartmann's procedure. One of the important primary outcome comparing the operative result of the primary anastomosis and Hartmann operation is a stoma reversal. In terms of the stoma reversal, primary anastomosis with diverting ileostomy had better outcome based on the meta-analysis, as shown in this slide. So, meta-analysis suggested studied with sigmoid colon diverticulitis, both Hartmann and primary anastomosis is equivalent in terms of the morbidity and mortality. As I previously showed you, primary anastomosis showed a better stoma reversal and reversal-related complications, because the complications concerning the ileostomy reversal is much milder, or sometimes the incidence-wise it is not that difficult operation. However, Hartmann reversal is very complicated operation, and we will face another anastomotic leak after Hartmann reversal. So those patients who are hemodynamically stable and immunocompetent patients, primary anastomosis is superior to Hartmann procedure. However, it depends on the peritonitis condition during the surgery. Today, I will show some cases. Before I introduce the cases, in my institution, we attempted a Hartmann reversal using a single port technique, and as shown in this slide, we started Hartmann reversal from the Hartmann colostomy site, and then using that Hartmann colostomy site as a entry point for the Hartmann colostomy reversal. So operation is not that easy. However, we can complete most of our cases with this single port technique. Today I will share two cases. Recently I performed the operation. So case number one is 49-year-old female. She had a history of abdominal pain and diarrhea, followed by fever for 3 days. The CT scan showed extramural air and inflammation at the rectosigmoid colon, as shown in the CT scan, and then the right side is the laparoscopic image at that time. So the inflammation was not that severe. So I found the perforation site, and then I decided to go through the sigmoid resection with primary anastomosis. So this time, I feel very comfortable about the anastomosis, and I did not perform the diverting ileostomy in this case. She had final pathology of PT3 and 0 and M0. There was no lymphatic, vascular, or neural invasion. However, she had a perforation, so she is undergoing FOLFOX chemotherapy right now. Second case is somewhat different. 58-year-old male presented to the emergency room with the history of 6 days of abdominal pain, and then abdominal CT scan showed multiple liver mets and severe peritonitis, as shown in this slide. The peritoneal condition is much ugly. So, however, I can perform the operation by laparoscopically. However, there are some unresectable tumor mass at the pelvic rim. So I marked here as with a metal clip for the future radiation therapy, and then I performed the Hartmann operation. So post-operative results show the PT4A, N1, and M1. There is one lymph node metastasis out of 16 lymph node retrieved. He had a lymphatic invasion, but there is no venous or neural invasion. His genetic marker for the chemotherapy is KRAS, LRAS, and BRAF for wild type. Microsatellite stable tumor. So he is undergoing the cetuximab FOLFOX chemotherapy right now. This is the video. For the interest of time, I will skip some of the video. As you can see, laparoscopic approach is difficult. However, if you do not give up the laparoscopic approach, it is not that impossible to perform the laparoscopic surgery even in this severe peritonitis condition. By using the laparoscopic suction irrigator, we can control the prurient ascites like this as shown in this video. So I collected some peritoneal fluid for the bacterial culture, and then I'm using, in this case, the bowel is very edematous and fragile and easy to damage by a laparoscopic instrument. So in this case, I'm using the endo-backup, endosponge for the dissection and holding the bowel. So I recognize the perforation site, and then I sucked all the necrotic debris and some pus like this. So as shown in this video right now, I'm using the endopena to move or to hold the edematous bowel in this case. So by using this endo backup, you can control the operative space. So I started the dissection near the promontory as shown in this slide, and then it is very difficult to find the exact plane, the suitable plane for the surgery because of the tumor invasion and also the peritonitis. However, if we are doing the surgery inch by inch, actually milli by millimeter, you can finally find the plane. Tumor is very hard and bulky, and there is a lot of peritonitis. It is difficult to hold or control the rectum specimen easily. However, step by step, I can find the retroperitoneal plane over here. And then by using endo suction irrigator and hook electrocautery, I can recognize the proper retroperitoneal plane over here, and then go through the pelvic, ready to go through the pelvic dissection. So again, this is a perforation site around here, and tumor is located around here. So this is the dissection of ilio inferior mesenteric artery here. So carefully dissect the inferior mesenteric artery. near the origin of the aorta, and then I placed some hammer rock. Even though I'm using ligature devices every time, I always apply hammer rock for the named vessel, like a inferior mesenteric artery, as shown in this video. So cut the IMA, and then to find out the plane, I found the IMV over here. So I made some bleeding during dissection, the IMV. So I decided to control the bleeding by a ligature device. In this case, the tumor is located near the pelvic promontory, and also the tumor is infiltrated to the pelvic sidewall. So it is very difficult to find the entry point for the pelvic cavity. So, however, finding the proper retroperitoneal plane just above the gonadal vessel is not that easy. So finally, I can enter the pelvic cavity as shown in this this video here. And this is the right side. Still, I try to resect all the tumor invading peritoneum, but it was not that easy at the time. So I decided to left some part of the tumor on the pelvic side wall, because en bloc dissection at this time was, I think, was dangerous at that time. So after mobilizing the rectum millimeter by millimeter, it is very tedious operation. However, after the operation, the patient recovery should be fine. So during the surgery, I told my intern, because this operation was done around the midnight, so I have no proper assistance. So I have only intern who is holding the camera. So I told my intern, so if I converted the operation to the open surgery, we cannot finish the operation between you and me. So I just continue to perform the Hartmann operation. And this is the, again, the left side of the pelvic cavity. So I can go through the peritoneal attachment near the bladder. Over here is the urinary bladder. So this is a tumor. So I can find the plane on the left side as shown in this video. So I can successfully approach the left side of the peritoneum. So divide the peritoneum step by step. And then finally, I started to trim the mesorectum here. I think this is the point where I transect the rectum. So I started trimming the mesorectum here. After clearing the mesorectum, and then divide the I think this is not a lateral ligament. However, this is the left lateral attachment of the peritoneum. So carefully divide the peritoneum step by step, and then this is the posterior wall of the rectum. So I divide the mesorectum over here. By using the ligature device, I cut the mesorectum, posterior wall, posterior side of the mesorectum, and then this is the anterior rectal wall and the left side of the mesorectum. So clearing the mesorectum on the left side.
Professor Lee, we have to move a bit faster
Okay,
because we
yes.
need more time for our trainees.
Yes, yes, sure.
Yeah,
So
thank you
cut
so much.
the rectum finally, and then as I mentioned before, there are some unresectable peritoneal metastases around the pelvic inlet on the right side of the rectal pelvic wall. So I place some metal clip. So in conclusion, ladies and gentlemen, Mr. Chairman, colleagues, even the emergency laparoscopic surgery is difficult, tedious. However, for the sake of the patient recovery, I think try lap first. If it is not possible, then open. Even though you are performing the open Hartmann's reversal operation, for the Hartmann's operation, for the reversal of the Hartmann, I recommend try lap again for the Hartmann reversal. Thank you very much for your kind attention and time. Thank you.
Thank you. Thank you, Professor Lee, for very nice presentation and video. I have some questions to you, but I'll leave it to the end of this section. So please stay with us. And
thank you.
So without further delay, I'd like to introduce our next speaker, Professor Leroy. Requires no further introduction. And currently, he's the founder and chairman of Hanai High Tech and Digestive Center in Vietnam. And he's going to share with us the lower GI benign and early malignant tumors, the development of transanal endoscopic surgery in a single center in Hanai, Vietnam. Professor Leroy, please.
Yes, many thanks for the invitation to participate to this a very interesting session of APELS. I'm really honored to speak of the transanal surgery, and I will choose my, sorry, I'm sharing. Where is
the share button is in the lower part of the screen.
I wish to see where it is. I suppose it is this. Optimize.
There should be a green button in the lower part of the screen.
I cannot share the screen. I don't know why. Oh, sorry. I'm changing this.
Once you click it, there should be some screen for you to choose.
But... Oh. I don't know why I cannot share my screen. So I do that.
Do you need some more time to fix it?
It said to that try another time. I don't know why.
Oh,
this is not working. So, share.
You share the whole
now,
desktop.
Perhaps. Is
Yes.
it okay now?
Yeah, it's okay now.
But I don't see where I am. I don't see you. Where I am. Ah, it is there. Okay.
Yeah.
So
We can see the slide. Yeah.
okay, thank you. Many thanks for the invitation. I have no disclosure. It is a very important surgical technique using a transcendental approach. And this is important because we can reduce the morbidity of surgical procedure, because before doing transcendental surgery for polyp and small tumor and eventually early cancer, we were doing very large surgical procedure as TME, low anterior resection with higher morbidity and not justified concerning the pathology. Now, originally, we were using the conventional transcendental resection for rectal tumor, but it was possible in a few cases, easy to be easy to access. But a specific equipment was developed and increased the possibility of resection. And in all the cases, and technique, the most important is to respect some principles and technical features. To remember, originally we were using Park's retractor or other type of retractor of valve to do a perennial local excision, or using the parachute technique. These are conventional local rectal resection we were using. But with a technical feature or recommendation or principle consensus concerning the margin of the resection, concerning the full thickness resection, and en-bloc resection with a pathological examination. The big revolution arrived 40 years ago and was developed by a friend, died now, Gerhard Buss, that introduced transcendental endoscopic microsurgery for the management of large or sessile rectal adenoma. And after it was used for early rectal cancer. As you see, it is probably the first notes procedures described in the literature. It was possible with sophisticated tools developed by Gerhard Buss with Wolf Company, using 3D video pictures, not video, 3D pictures and optical pictures, and very expensive because the cost at this moment was around $100,000. Since more or less sophisticated product, as for example the TEO transcendental endoscopic operating platform developed by Storz, were introduced on the market. It was cheaper, and this was possible because we have seen during the last decade the development of video laparoscopic procedures and endoscopic procedures, and we can adapt all the laparoscopic system, platform, and instrumentation for doing perioperative transcendental surgery. We have also other possibility of platform, soft platform as transcendental seals or gel point or other. And personally, I use the transcendental rigid platform, reusable platform. This is the S-Portal platform, used with the TU trocar to facilitate the surgical procedure. The advantage, it is fixed to the operating table, and we can have the scope introduced, and we can do solo surgery. That is very important to reduce the cost. You see the system fixed, the camera is fixed, and the surgeon can work alone, watching on the screen in front of him. You can put all type of camera. And what are the indications? There is a consensus. We can use for adenoma. We can use for mucosal, submucosal benign tumor, as for example, the carcinoid tumor or stromal tumor, we will see. We can use also for early carcinoma of the mucosa, submucosa, T1 tumor, well differentiated without positive nodes, without vascular invasion, and for tumor with a size less than 3 centimeters and in appropriate localization. This is full thickness polypectomy. So we introduce the system, and you see the smoke is evacuated by ventilation of the space, and we can use a simple instrument as a hook for doing monopolar excision, even if the polyp is very big, as we have in this case, and slowly using different type of energy device, as we have seen. We have begun with monopolar, we have used ligature, and we will see Thunderbit later. At the end, we can do sutures, and we have to train for doing sutures. We will discuss of that. As you see, we can do, personally, I prefer to do separate stitches for doing the sutures. And this is what I recommend to do for having a dehiscence, a large dehiscence in case of post-operative complication. We have the possibility to remove, this is a small carcinoid tumor, and you see we do the delimitation, and using a new energy device, it's easier because we have a good hemostasis, and we do a larger resection. This is another case of resection, and as you see, we have resected in contact with the sphincter, and it's easy for doing this with a perfect control of the margin and the perfect control of the sphincter. The problem is when the tumor is very low. As you see in this case, we are in the anal canal, and this is one of the advantages of the rigid system as TO I'm using, because with the flexible one, with the seals, with the gel port, we have to introduce the system above the sphincter. So we can do the resection with a perfect control. We can do also ESD resection. We know that our endoscopists, gastroenterologists are doing this, but we can do through also with very perfect and faster technique than the endoscopist. We go faster because we don't hesitate to do very deep and full thickness, sometimes resection, because if there is a perforation, is not really a problem for us, because we can do sutures as you see at the end after a large mucosectomy or submucosal resection. And we can do the suture to avoid local complication. This is more interesting when we have stromal tumor, for example, of the anterior rectum. This is a big tumor of the anterior wall of the rectum. And we did the biopsy and we have discovered it was a stromal tumor pushing the prostate. And we decided first to do medical treatment with Glyvec. And after 6 months, volume reduced 50%. And we decide to do the resection by transcendental approach. We put the patient in prone position and we did the resection, as you see, using a monopolar spatula from Olympus, spatula used by Junji Okuda to do his surgery. And we did a complete resection, R0 resection, and with an easy approach, because the volume was reduced, as you have seen. We have done, we see the prostate at this moment, and we decide to resect completely and to do a sutures at the end. The tumor is at the top of the video, and we decide to do the complete resection, removing the mucosa and removing the tumor, respecting oncologic principles with R0 resection that was confirmed by histology. And this is the end of the resection. We remove the tumor, as you see, and at the end, we did the sutures, and we complete, after controlling hemostasis, we did the sutures, and this is what we have at the end of the procedure. Our results, my young assistant, Dr. Dan, did more than 30 cases now, and always removing the completely with R0 resection. This is the next two cases we will do, two new stromal tumor with different positioning. You have one that is posterolateral right, another one that is anterior, and we will do Glyvec medical treatment that is just begun, and we will do transcendental resection when the volume will be reduced. This is why we can have indication of doing perirectal tumor as a lymphoma, for example. For cancer, only to remember that the gold standard is the TME in cancer. So if we have to do transcendental resection, it's local resection with full thickness. It is for T1 tumor. But the problem is we have no lymph node staging, and we don't know exactly the oncological results. Even if in the literature we see good results, les autres, for example, complete or begin by irradiation. This is a case of a patient that had multiple resection for benign polyp, and with a doubt concerning this tumor, but no positive biopsy. And I decide and I consider that it was a potential rectal tumor, and I did a resection, but removing the meso around distally. It's not a TME, it's a distal mesorectal excision, with a distal rectal excision. And finally, I removed, and it was a cancer with 1 positive node in the meso. So we have to know that for doing more. So this is a high rectum we are resecting, and we will do colorectal anastomosis with sutures. It is why it is so important for training people doing sutures. And this is what we will have at the end. We will have a low colorectal anastomosis. And the follow-up, this patient was operated in June 2010, so 12 years ago. It's always very well, actually. So this is what we did. So the next step will be, but we have a discussion concerning this in next November, the TME by transcendental approach or sigmoid resection by transcendental approach. I do, but we will discuss of this, and the best will be probably a pure transcendental TME, that is a minimally invasive transcendental approach with dissection and ultra-low colorectal coloanal anastomosis through the transcendental route. This is completely innovative, challenging, and promising technique to treat selective rectal cancer without diverting stoma. Question: if we do a perforation, you see, for example, when we have anterior polyp above the peritoneal reflection, that is around 9 centimeters from the anal verge on the anterior wall of the rectum, what to do? When we do a full thickness resection, we see in red the full thickness area resection without risk of peritoneal perforation. In this area, we will have a risk of perforation. What we will do? This can arrive in up to 10% of cases. And we can enter by inadvertent or intentional reason. Surgical option, you have seen I do sutures. We can do TEM sutures, the by TEM approach, transcendental approach. We can do a laparoscopy to do the suture by laparoscopic way, or open if we are not skilled by transcendental for doing the sutures, and sometimes some authors propose to do, but I don't recommend low anterior resection. What are the consequences of a perforation when we are doing resection of a small rectal cancer? In the literature, this is not associated with a major complication or oncological compromise evolution. Post-operative dehiscence after sutures. This can arrive in 20% of cases. Majority of people are doing running sutures. It was the proposal of Gerhard Buss. And personally, I prefer to do separate stitches. It's perhaps longer, but I think it's safer because you can have a tension, particularly if it is easier to do a running suture with Vloc, for example. So we will have postoperatively pain, hack, fever, night sweat, mucus drainage, and pus coming by the anus. Pelvic sepsis may be more common, particularly for the low rectal lesion. The treatment recommended is only oral antibiotic and analgesic. What to do when we have a defect? To close by sutures or to leave open? There was after we have a dehiscence, randomized control trial, including 22 patients in each arm. I've seen no difference when concerning the post-operative bleeding, the stenosis, or the wound healing that will be controlled in 4 weeks in the majority of cases. Concerning the fecal incontinence due to the transcendental way we operate the patient. Why? Because we use a big trocar introduced a long time in through the anus. Is it damaging? This can arrive for 1 to 5% of cases, but it is temporary. And usually you will have just soiling, incontinence, toothless, and transient. In conclusion, transcendental endoscopic surgery is technically demanding. Transcendental endoscopic surgery increase the indication and result to cure rectal benign tumor and early cancer, comparing with traditional open surgery with less morbidity. Due to design equipment and skill developed with surgical Endo-Lap training, surgeons are more able to perform transcendental surgery, reducing extended rectal resection, improving functional result with faster recovery. Training must be done in advanced training center with experts to have very rapidly good results. Thank you for your attention. I have no sound. Dr. Fan? We have no sound.
Can you hear me?
Now, yes.
Okay, sorry. Thank you, Professor Leroy, for your presentation on the transcendental surgery. And we'll leave a Q&A section in the later part of this section. And then there's a polling question posed by Professor Leroy. In case of intraperitoneal entry during TES procedure, recommend to maybe can our audience fill in the answer while we wait for the next speaker. Our next speaker is Dr. Supakij, who is a very famous endoscopic surgeon in Thailand and internationally. And he's going to share with us the endoscopic polyp excision, the video presentation. This is something must be very interesting to surgeons, because the surgeons only in a few countries they are trained with endoscopic skills, but in most of the countries still endoscopy is still governed by the physicians. So we'll have some more tips and tricks from Dr. Supakij.
Okay, thank you very much for your kind introduction. So let me start my presentation. Good afternoon, ladies and gentlemen. I would like to thank you, the organizing committee, to give me the opportunity to share my experience today. And I am Dr. Supakij Khomvilai from Surgical Endoscopy, Chulalongkorn Hospital, Bangkok, Thailand. My topic is endoscopic polyp excision. This is my hospital in the center of Bangkok, the capital of Thailand. I am a colorectal surgeon and my main work is colonoscopy. I take care of our surgical endoscopy center in our hospital. Because of the screening program for colorectal cancer, made us found more lesions in the colon and rectum. For this lesion, invasive colorectal cancer, they need surgery for oncologic resection and imagine that is located deep down in the male pelvis who have big belly. It's not easy to do TME as standard rectal cancer surgery. And these are the results after surgery, either laparoscopic approach or open surgery. We need surgical wound to enter abdominal cavity and sometimes colostomy was created. Complications after corectomy are roughly 20%. Even with the laparoscopic approach are the same. But these are just immediate complications after surgery. They have more complications later, such as gut obstruction, foam adhesion, and complications related to ostomy. As the same for rectal surgery, complications are roughly 22%, even with laparoscopic approach are the same. Compared to endoscopic resection, this patient is not easy to do surgery for him, but he underwent ESD for ascending colon lesion, and post-operative day 1, he can enjoy walking around the hospital and go back home in a few days. The data of ESD procedure from National Cancer Center Hospital, Japan, they found perforation 3.5%, and almost all of them can manage by conservative treatment without surgery. And the same for multi-center data analysis for ESD procedure in Japan show 5% perforation rate, which need emergency operation only 0.4%. From these data, it seems be better for the patient if we can do endoscopic treatment for the colorectal lesion we found, but not all of them we can do endoscopic resection. We can do endoscopic resection for colorectal cancer if there are no risk for lymph node metastasis. But if they have a chance to have lymph node metastasis, surgical resection should be performed following oncologic resection principle. And we have to keep in mind that if there are carcinomatous area, it should never be cut into pieces. It needs en-bloc resection. NCCN guidelines recommend treatment strategy for malignant polyp following morphology, completeness of resection, and histologic feature. In this guideline, TIS or carcinoma in situ is not counted as malignant polyp, and surgical resection is recommended based on the morphology, completeness of resection, and histologic feature, without mention to the depth of tumor invasion. So most of T1 colorectal cancer patients in Western country underwent surgical resection. But from our own data, surgical endoscopy, Chulalongkorn Hospital, we found lymph node metastasis, 10.4% in T1 colorectal cancer. From this data, 9 from 10 patients do not need surgery to remove lymph node. Only endoscopic resection as local treatment is adequate for oncologic resection. Thanks to our Japanese endoscopists, they found that malignant polyp are classified by depth of cancer invasion as intramucosal cancer, superficial submucosal cancer, and deep submucosal cancer. The cutoff level of tumor invasion is 1000 micron from muscularis mucosa. If the cancer invades beyond this point, it have a chance to have lymph node metastasis. And with the superficial submucosal cancer without lymphovascular invasion or poorly differentiation, they have very low risk to metastasis to the lymph node. So in that JSCCR guideline 2019, they recommend to do endoscopic resection for TIS and T1 colorectal cancer if the depth of submucosal invasion less than 1000 micron, without lymphovascular invasion, no poorly differentiation component, and no budding. So it means that for invasive cancer or deep submucosal cancer, we have to do surgical resection to remove lymph node because they have a chance for lymph node metastasis. But for early colorectal cancer, which is intramucosal cancer and superficial submucosal cancer, we can do endoscopic treatment as local treatment and is adequate as oncologic resection. So we as endoscopists apply this knowledge to our treatment strategy when we found the lesion. We do in vivo characterize the polyp by using magnified chromoendoscopy, either NBI or dye like indigo carmine or crystal violet. Then design proper treatment for the patient, surgery for invasive cancer to remove lymph node, or endoscopic treatment, which have several techniques nowadays. Polypectomy, cold snare are very popular right now, EMR or ESD. We use night classification to classify polyp and design proper treatment. Night classification, we look at the color, vascular pattern, and surface pattern of polyp. In some cases, we need more detailed observation by magnified colonoscopy. Genetic classification are essential to differentiate malignant polyps. The most important is Genet 2B lesion, which consists some invasive lesion. With the power of new endoscopy system like Olympus EVIS X1, we can detect more lesions and give accurate characterization by using better image enhanced technology like NBI. Then we can choose the proper treatment for the patient. You can see more details in my YouTube channel, so please scan QR code to check it out. I also use EMR technique for pedunculated polyp like this. Diagnosis was made by NBI, and this is nice type 2. For the EMR, the injection was done, then snelling. But for pedunculated polyp like this, I use coagulation mode rather than endocut, which contain cutting currents, and we made bleeding occur. So please be careful, check your current setting of electrosurgical unit, then proceed the resection. After the resection, I usually close the resected wound by endoscopic clip to prevent delayed bleeding like this. And these are bigger lesions. Both are nice type 2 by NBI observation. And you've seen the vascular and the surface pattern show nice type 2. And my endoscopic diagnosis is tubular adenoma. For the EMR, the injection was done by the saline plus indicocamide. And the snare was placed around. And I usually cover the normal mucosa to achieve the negative margin. Like this. And sometime after the cutting, the bleeding was occur. Then I use the coagulator to control the bleeding point, like this, and then close by endoscopic clip. After resection, the specimen should be expanded and fixed before transfer to pathologist for microscopic study. These lesions have depressed area in the center of the lesion, which show nice type 2 Genet 2B in the central area by NBI. My diagnosis is early cancer or non-invasive malignant polyp. So I did EMR for this lesion to make sure that I got negative margin from the resection. The pathologic study came back as intramucosal cancer as our endoscopic diagnosis. As the same with previous case, this lesion located in upper rectum and have depressed area. Morphology type was 2A plus 2C, and NBI diagnosis is nice type 2 and Genet 2B. So my endoscopic diagnosis is non-invasive malignant polyp, and I decided to do the P-cutting EMR for this lesion to secure the negative margin. For P-cutting EMR, circumferential mucosectomy was made by using dual knife, like this. And then following by the snelling, the lesion out, like this. So you can get the negative margin from the mucosectomy that you made previously. And close the dissected wound by endoscopic clip. The pathologics come back as modulative adenocarcinoma intramucosal cancer without lymphovascular invasion and a free margin. Additional CT scan show that no metastasis. Next, how about this case? Do we need surgery for this lesion? First case, screening colonoscopy show lesion located at the ascenic colon. 2A plus 2C lesion, size 1 centimeter. This depressed lesion have more chance to be invasive cancer, especially in the depressed area. In this case, from NBI diagnosis is night type 2, Genet 2B. My endoscopic diagnosis is non-invasive malignant polyp. Size is only 1 centimeter, and I choose to perform EMR for this lesion. Pathologic study show intramucosal well-differentiated adenocarcinoma without lymphovascular invasion or tumor budding. Margin is free, and additional CT, chest, and abdomen didn't find any metastasis. 1 year surveillance show healed EMR scar without local recurrence. Second case, 3.5 0 plus 1S lesion found at lower rectum, and the patient have change in bowel habit. And this is NBI magnification at depressed area in the center of the lesion. Indigo carmine showed an NBI was applied. Also magnification at depressed area. Magnified NBI diagnosis is nice type 3, Genet 3. My endoscopic diagnosis is invasive malignant polyp, and I recommend surgical resection for this patient because there are chance to have lymph node metastasis. Pathologic study of surgical specimen show T1 moderate differentiated adenocarcinoma. Submucosal invasion is 3,356 micron from muscularis mucosa without lymphovascular invasion or budding, and luckily there are no lymph node metastasis in this patient. Next one, 3.5 centimeter, 0 plus 1 SP lesion was found at upper rectum, and with magnified NBI, my diagnosis is night type 2 and Genet 2B, non-invasive malignant polyp. My approach to resect this lesion was ESD or endoscopic submucosal dissection, and the principle is dissecting into submucosal layer that we made by inject lifting solution, which in my case is the mixture of the glycerol, adrenaline, and indigocamin. After the cutting, like this, and you see that I usually use the cap and the taper cap that I use is to help us to open the wound and get into the submucosal layer and keep cutting into the submucosal layer like this using the help of the cap as a traction. So we can get into the submucosal layer and then we'll keep cutting by using the dual knife. Additional injection was done and then keep cutting into the blue layer like this. So this is the ESD or endoscopic submucosal dissection. The procedure time is 2 hours. Pathologic studies show well-differentiated adenocarcinoma with submucosal invasion only 50 micron from the MM without lymphovascular invasion or budding and with free margin. Surveillance colonoscopy show ESD scar without recurrence at 7 months. This patient is very happy that he got the benefit from endoscopic resection without any surgical resection or colostomy. The last case is the 7 centimeter lateral spreading tumor, granular nodular mixed type, located close to the anovert. NBI observation didn't show any sign of invasive pattern. My diagnosis was night type 2, Genet 2A, and I think it will be tubulovillous adenoma. I recommend ESD for procedure for the patient. The procedure was done successfully without any complication. Procedure time was 4 hours, and pathologic studies show tubulovillous adenoma with high-grade dysplasia without lymphovascular invasion. The patient was really happy without any colostomy created, and X-month surveillance didn't show local recurrence. And these are the other specimen for the ESD procedure. And then some of the lesion was big and the procedure time was so long. But the patient is also happy. They got the benefit from the endoscopic resection. So I show the cases that we apply endoscopic diagnosis for the depth of the invasion to choose proper treatment for the patient. If you think that lesion you found can get the benefit from endoscopic resection and you cannot do it, so please send the patient to the center that can do without taking biopsy or the tattoo. Just take a photo is enough, because it's really difficult for endoscopic resection later for the tattoo or the biopsy. So please keep in mind that if there are any parts of the lesion was suspected cancer, it should be resected by en bloc resection. So in the conclusion, ladies and gentlemen, the power of nowadays technology of colonoscopy make we can get accurate characterization by detailed observation of colorectal polyps, then remove by proper and safer procedure, including oncologic resection for early colorectal cancer. Polyp characterization is important and can help endoscopists and surgeons to give a chance for the colorectal patient to get better quality of life after the treatment. So thank you very much.
Thank you, Dr. Supakij. Very nice presentation. I have several questions, but again, we'll leave it to the end of this session. Thank you so much. So may I introduce our next speaker, Professor William Chen, and currently the superintendent in China Medical University Hsinchu Hospital in Taiwan. Professor Chen, we're going to share with us the talk on the future of laparoscopic and robotic colorectal surgery. Professor Chen, please.
Okay. Well, thank you very much, Joe, and thank you, Michael and APEL, for inviting me once again. And I think this topic will be broad, and I'll keep my time, and hopefully that I can finish it on time, right? So, well, I'm working in a 500-bed hospital now in Hsinchu, and this is a very nice place to work on. And currently, we are performing more than 300 colorectal surgeries per year. And I think for the last 115 years, colorectal surgery have moved on from an open surgery to a minimally invasive surgery. As we know that because the surgical care have been changed, we have been digitalization, miniaturization, and improve our optics during surgery. And also the images are brought into the OR so we can do better surgery. And also many of our charts and operating systems are computerized. So early days in laparoscopy, there are many controversials as people are questioning about laparoscopic surgery. But however, from the literature back then, it was showing that laparoscopy have less blood loss and less ELIs and less pain, less mobility, especially with infection, and decrease of hospital stay, and less bowel obstruction after surgery, and less hernia, and better cosmesis. And the cost probably might be better now as compared to the days we were starting our laparoscopy. And also the immuno response is better, and the cost, of course, now is less, and survival rate is better when performing a laparoscopy, especially on stage 3. And this has been proven on the Barcelona trials. And prevention of urinary and sexual function because you see better. So now we apply many things in laparoscopy, using laparoscopy such as CME, TME, nose, and PLND, ICG, and intracorporeal anastomosis. So as for TME, I think everyone knows that TME using laparoscopy is much better than open TME. So you can perform a very good TME with good spacement retrieve from TME. And also you can do complete mesocolic excision, especially, I think it's much easier performing an extended right hemicolectomy with D3 dissection, or we call it CME with central vascular ligation. I think it's much better with using a minimally invasive technique. But one of the questions that's been always been challenged by open surgeon is that for standard laparoscopy, we need to retrieve the tumor from or our specimen from immediate laparotomy, so it doesn't make any difference while as compared to open. However, we are utilizing our natural orifice to remove the specimen. You can do it transanally or transvaginally, and also can use the transanal endoscopic laparoscopic surgery. And we also can perform Thomas or TATME and management complication. As you can see, the specimen retraction after sigmoid colon cancer, which now is a standardized, we standardized this operation in my institute for a small tumor that's less than 3 centimeters without a bulky mesocolon. We would routinely perform a nose operation. And we also can invert the rectum and then do a remove through it and then do an anastomosis. And also we can perform laparoscopy for pelvic lymph node dissection. I think it's better. It's much easier using a laparoscopy as compared to open surgery back in the days that we don't have a laparoscopy. So it's easier if you're performing this operation because you can see better, and also there's a pneumo effect while you're doing the surgery. And also we use a transanal procedure, a platform to perform surgery. I think Gerald have already told everyone about this. And now the most common procedure that we perform is the Thomas. I call this as transanal ESD. I perform it only for rectal cancer surgery. And I think it's really good for this operation to do it transanally. So I inject that with I call it, this is a water ejection. So I lift up the submucosa by using a water injection machine to inject the submucosa. So lift up the submucosa. And then I'll perform a Thomas. I call this a transanal ESD. I think it's almost the same as ESD by colonoscopy. But I think in rectum, it's easier to perform this type of procedure using a transanal device, and also it's faster. For this type, for this tumor, you can finish it within 30 minutes at the most. So this is one of the options that we're performing right now. And then we can also using this method to treat complication. If it's a leak, we frequently will go inside the abdomen and clean the abdomen, and then we will repair the leak, and then we'll pull it and ileostomy. This has been published in 2008 on surgical endoscopy. And now we are looking into the long-term outcome for this type of patient. And it's undergoing submission. So this is I think it's a very good procedure, although it's not, I think it's an option when it's a leak with a good blood supply. You can just repair it and put an ileostomy, and you can close the ileostomy soon, faster than you just leave the defect there. And also we perform TATME by using this procedure. And then recently we perform many, to save the sphincters, and we perform many turbal coatate through colorectal anastomosis by using this, the transanal platform. And utilization of ICG is what we are doing right now. So we are doing a lot of, many of ICG, especially for tumor coatate. before closing it, perform an ICG, and then we do a coloanal suturing. So this is what we are currently doing it. And also, we would like to utilize colonoscopy during surgery. And I think we frequently, almost always use a colonoscopy to identify the tumor during surgery, small tumor during the surgery. And I think it's a very good method of identifying the tumor and checking on the distal margin as well. So colonoscopy is one of our weapons doing colorectal surgery. I think all colorectal surgeons should perform colonoscopy, and also we can perform colonoscopy to check our anastomosis during surgery. So this is we always check our anastomosis after the surgery, so for it's intact. And what's good about this is you can also treat complication after anastomosis. This is low anterior resection, TME, and then we found that there is a bleeder during surgery, doing a colonoscopy. So by checking it, we can clip it as soon as we discover there is a bleeding. So I think it's very good to perform a colonoscopy using doing the surgery. So I think like endo-laparoscopic suite is the future to go. So Michael has been using this for a long time, but I think a lot of surgeons around the Asia are not doing this, especially colonoscopy during surgery. Okay. So I can clip it like this. Also, I use a colonoscopy to remove the tumor, the proximal tumor. I performed this for a spatial and pull alpha endoscopy for a benign lesion or early cancers. And then we perform, and after putting out through the anus, and then we perform an intracorporeal anastomosis. Therefore, we don't need an additional excision for the tumor. So there are limitations for laparoscopy, as everyone knows, that for obesity or patient with a large prostate or uterus, you probably found that it's hard for us to perform laparoscopy. Therefore, maybe robotic surgery can solve this problem. As we know that there are many benefits of robot, also there are disadvantages of robot, such as loss haptic sensation and tactile feedback. And I think docking and undocking and curves on robotic arms have been solved with the new robot, the XI, and a multiple quadrant surgery is no problem with the XI. Increased cost, and it all depends on how you look at it. And I perform many robots nowadays. For three to 4 month period, I've done 45 cases of robot, and I perform a robot. This is a robotic nose operation. So I think it's easier than compared to laparoscopy with the robotic nose. So this is how we perform. You can perform with the suturing easier. And I think with the robot, you can avoid all the tremors that we do, and you can easily tie the thread while you're performing the surgery. So I perform many robotic nose surgery nowadays, and I think it's a way to go for robotic surgery too. So you can suture with the robot; it's much easier. And then I perform also end-to-end intracorporeal anastomosis using robot. And one of the good things is robot has ICG, the Firefly system. So it's much easier performing the end-to-end staple anastomosis. And nowadays, I would like to suture the end-to-end with the robot, and it's a lot faster and it's more cost-effective. So you don't need to use another staple to close it. And we also perform robotic pelvic dissection. So this would be very easy using a robot, and you can see much better. So the robotic pelvic sidewall dissection is the way to go. I think it's much easier with as compared to laparoscopy. Although there won't be any significant when you do a compare, but I think if you do the robot with this, using a robotic surgery to perform a pelvic sidewall dissection, it's much easier as compared to laparoscopy. I also do a robotic CME. I think also it's a good option when you're performing a CME because you have an additional arm to help you, and you can move your own camera. And I think if you're performing a CME without trimmer, and at first I was a bit scared of performing the robot on colon cancer, but now if it's suitable, and I will perform this surgery, but using but even robotic surgery. And also when you perform intracorporeal robot with the robotic stapler, it's safe and feasible as compared to the laparoscopy. So now I think the current robotic system actually is not a robot, but it's just an expensive laparoscopy surgery using expensive camera and arm holders that avoid trimmer. But I think by performing robotic surgery makes my surgery much better. And now, although the current robot is not a robot, it's a master-slave system. But I think surgeons should adapt to it. So for the last 4 minutes or 5 minutes, I would like to talk about the surgical development nowadays. And now we are into the future. So now we have multiple medical images in the OR, and we have laparoscopy and video-assisted endoscopy and computer and robotic assisted intervention. How are we going to put all this together in the near future? I think we should think about it. The current problem is that we are not integrating the computer aids in our surgical environment. We don't have this environment at this moment. And surgeons are not really thinking about their ergonomic while doing the surgery. And our work is not really cognitive. So we spend a lot of time like setting up our patient. We don't have a standardization doing the OR. So the turnover rate is a bit longer. So I think currently our electronic patient record is fragmented. So this is something that we need to work on in the near future. So currently, this is what we are doing right now. We do have a domain knowledge now. We have case knowledge, and we have we have gender difference, and we have all the vital signs here, and we have computer. We have a CT scan or MRI or PET scan, and we have our pharmacists, and we have vital sign taking, and we have endoscopy. But we are not putting all this together at this time. So in the future, we will put all this together. So therefore, a surgical data science is very important. I think a biomedical data science focusing on procedural data is important. We should focus on the patient, and we should have all the effectors involved, such as surgeon or anesthesiologist, the anesthesia team, nursing, and device. We should gather all this information, all the procedure-related image, vital signs, we have a medical device data, and we have our motion data, and we should capture all this, and then we should put this the domain knowledge, such as factual knowledge and our practical knowledge, such as our workflow, our clinical practice guideline. We should all join this together and put it into as a whole. And then we'll have a complete map of our future surgery. And also, I'd like to mention about OR, as like Olympus has an easy sweat, which you can control all the lights, you can control all the images. And it should be, in a near future, it should be a speech control OR, and it should be automation. And the infrastructures of the future will be very different from now. And we should simplify the way we work, and we should install the digital twin into our OR setting. And also we should carry on this to our training. Currently, we have a Inamet training, animal model, cadaveric, pop trainer, and virtual reality. And we should think about our future training. Our future training should be more rely on augmented reality as well as the virtual reality. So at the end, I would like to say that artificial intelligence surgery is very important. We should have captured our images or our video clip for machine learning and deep learning, and also we should capture like the computer vision and showing that in the future we go ahead and analyze all our procedures, our videos, and adding on the natural language process into our surgery. So at the end, our future direction probably would have a surgery with robot and with all the computer aided system in our OR. And I thank you very much for your attention.
Thank you, Professor Chen, for your nice presentation. And currently, we can now move on to the Q&A. May I invite all of our faculties or speakers to come together and see if we got any questions from the floor. We have a few minutes for the Q&A section. Maybe I can pose the first question to both Professor Leroy and Dr. Supakij, and probably Professor Simon. In the lecture, we heard that for the low rectal lesion, we can do it either with the Transcendental excision or by the endoscopic submucosal dissection. So already there's some current evidence showing that maybe yes is better. I would like to listen to Professor Leroy and also Dr. Supakij's advice on this approach to the low rectal lesion, and probably Simon can give us some input on the study.
Okay, maybe Professor Leroy first.
Yeah, Professor Leroy.
Activating. Okay, it is done.
Yeah.
Do you hear me? Yeah.
Yes.
Yes.
So, can you repeat the question? Sorry.
So do you prefer transcendental excision versus endoscopic submucosal dissection in the treatment of low rectal lesion?
For what? For cancer or for benign?
Both benign and probably early malignant lesion.
No, for benign, it is transcendental. Yes, transcendental. Majority of cases will be done by transcendental.
Mm-hmm.
For cancer, we can, in selected cases, not to advance tumor, we will combine eventually transcendental and laparoscopy. It is what I call hybrid transcendental procedures. For me, if we have a polyp of the mid-rectum that is a cancer, we can do pure transcendental TME, and doing colorectal anastomosis without diverting stoma.
Yeah.
Okay.
Thank you. How about Dr. Supakij?
Yes, thank you very much for the question. So for us, the approach for the lower rectal lesion, it depends on what we found, and we usually use the NBI to characterize the lesion that we found first. And if the lesion is filled or found that it have the invasive part, which means that it have a chance to go to the lymph node. Our approach to the lesion is a surgery, laparoscopic surgery. But if the lesion is not showing any invasive pattern, so the endoscopic is first, the ESD or EMR or P-cutting, any other procedure that we can do with the endoscopy. We starting with it first. And then if we cannot do that, or the surgical specimen came back with the pathologic study, which showing that it have a chance to have the lymph node metastasis, we go on for the additional surgery.
Yeah, thank you, Simon.
All right, thank you, Joe. Supakij, and also thank you, Professor Joe Laurel. So now I concur with Supakij. I think it first really depends on the nature of the lesion, okay, after your thorough endoscopic assessment. If it's benign, then I think it really depends on expertise, all right? If the patient goes to see Supakij, will be obviously ESD, all right? If the patient goes to see Joel, will be Transcendental. So it really depends on the expertise. But if you have a surgeon who can do both, so that's a question, right? Whether you would prefer, and if it's a benign lesion, then whether you would prefer to have a ESD or Transcendental. Now, back in Hong Kong, I have completed a randomized control trial last year, ESD versus TAMIS for early rectal neoplasms, all right? Majority were actually benign with some T1 cancers. So now my study was prematurely terminated midway because I've already shown positive results in terms of safety and also efficacy data. My study showed that the ESD arm was associated with shorter hospital stay and also lower morbidity, which was the primary outcome, all right, of the study, favoring ESD arm, all right. And in terms of the en-bloc resection rate and also complete resection rate, I think is equivalent between ESD and also TAMIS in expertise hands. So based on my studies for lower rectal tumor, if it's not malignant, of course, as mentioned by Supakij, if it's a locally invasive SM3, will be surgery, all right? But if it's early T1 or benign, I think based on our studies, I think will be ESD.
Yeah. Professor Lee, you have some comment?
Yes, actually, for the very low located rectal cancer, rectal tumors, which is benign or early malignant, the endoscopic procedure takes a lot of time and have many difficulties compared to the Transcendental approach. So in those cases, Simon, what do you think about the procedure-wise, the difficulties comparing the endoscopic treatment and the Transcendental treatment?
Yes, Suk-Hwan, thank you. So now for very, very low lesions, I think Supakij will also think it's difficult with endoscopy because of air leak, right? Very, very low rectal difficult, all right? But now let's talk about operate the procedure duration. I think obviously a lot of people think that endoscopic treatment will have a longer operating time, but in fact, from my study, actually they are more or less the same, all right? It's not much longer than Transcendental excision, the top about endoscopy. But obviously it depends on case selection, because if you look at Supakij's presentation, those 20 centimeters lesion, obviously I think those will take a few hours to complete.
That's right.
Selection, I would say, at the end.
Yes.
Yes, actually, can I add some comment to the question of Professor Lee? Actually, the low rectum is a little bit difficult in terms of the technique. But if you are familiar with the technique, so the low rectum have a little bit tricky technique to do that. It's difficult. It's different, a little bit different from the approach to the mid or the upper rectum or the other part of the colon. So if you're familiar with that, so it's not so difficult. As Simon said, that is the procedure time is depend on the expertise. So previously, in the 5 or 6 years ago, my procedure time is a little bit longer than now. So for now, the lesion is not so complicated, 5 or 6 centimeters. So my procedure time now is 30 minutes. So it's the yes, it's the shorter. I think it's maybe it's shorter than you docking the TAMIS equipment. So like my anaesthetist said that it's just starting in fusion the muscle relaxation, and then I finish the procedure. So it depends on the expertise of the endoscopy. So yeah, that's it.
So you are doing the endoscopic removal in the OR with the general anesthesia?
No, in the endoscopy room.
Endoscopy room.
Yes, but my endoscopy suite have everything that the OR have, maybe more than the OR.
So will
I have some comment on the rectal lesion. I have the same thoughts like Professor Lee. If it's up in the sigmoid or descending colon or some proximal colon, I think ESD would be the choice of my treatment. But if it's in the rectum, I think you see my video of doing a transanal ESD. My patient get out of the hospital in the afternoon after I perform it in the morning. So without any because a lot of surgeons around the world doing the transanal procedure do not lift up, inject the submucosa and lift it up. Try it if you inject it. So I think it's faster than endoscopy. Even my one of the experts in doing ESD, my GI man, he came in and he said that if it's a tumor that's 5-6 centimeter, it's faster using a transanal ESD using the TAMIS procedure. That's my comment.
Good.
Yeah.
Professor Choi, Leroy.
Joe?
Yes.
Yes,
thank you. I'm happy to see all my friends. And William, I'm saying congratulations for his lectures and all the comment he did. And I agree with him because I said also in my lectures that probably it is faster. And Simon said he did a study and analysis of the experience, but it is interesting to know concerning the position of the polyp, which technique, which equipment people have used. I'm speaking of surgeon, not the endoscopist, but I see that they are always saying it's difficult for the lower rectum, but my experience and the experience of my good friend Frédéric Bretagnol, that is not using the same equipment I have, is completely different. When he is using, as I do, the TEO platform, it's easy to do very low rectal tumor. When he's using seals or gel point, impossible for him working easily. So this is important to know which kind of equipment people are using also for doing, because it's technically dependent for and experience is also important. So I think both techniques are interesting, but if we want to go faster, we have to train and we have to have good equipment.
I've just got a small point, Junheng. Thanks for all the lectures or all the professors and friends here. I think I agree with all that the technique makes a difference and you need to train. So I think just like what Simon's unit has done in the surgeons doing ESD, like for myself, I started doing EMR ESD for the last 8 years, and I do TAMIS and I do transanal resections as well. There is a choice of what you want to do depending on what is available. And if you're trained in those, if we have the fortunacy of doing that, get to almost Dr. Supakij skills as well as Leroy and Professor Williams skills, then you have a choice for the patient when some patients prefer an endoscopy approach because they feel that it's not an operation. And you do that maybe for the higher lesions. If it's a rectal lesion that is bigger and you want to be able to do something like William or Leroy with TEO, I think if you're, what we want in APELS is for all to be if possible, to be well trained, and then you can do both, either ESD and the transanal approach if your volume in the center allows. Thank you.
Yeah, thank you all of your comments from faculties and speakers. Probably it's time for us to move to our next part of our webinar, which is very interesting and exciting, because we have competition for our trainees to win the best presenter award. So today we have 4 trainees or junior surgeons to present their case. May I now introduce our first lead faculty, Professor Simon Ng. Currently is the chairman of the Hong Kong Colorectal Pathology, and also currently is professor and division chief of the colorectal service in the Chinese University of Hong Kong. Professor Ng, please.
Oh, thank you very much, Joe. So very happy, very delighted to introduce the first speaker. I think Dr. Praveen, I think he is a colleague of Craig from Australia, right? So Dr. Praveen now is a consultant colorectal and robotic surgeon working at Australian Robotic Colorectal Surgery Center at Sydney Advanced Hospital in Sydney. So it's a colleague of Craig. So now he is going to talk about a very interesting topic. It's anastomotic leak in morbidly obese patients undergoing ultra-low anterior resection. So I think it's really a technical challenge. So it's all yours, Praveen. All right, so we can discuss about your talk after your presentation.
Thank you, Simon. Can you hear me?
Yep.
Thanks. So this is a case that I did. It's actually a case of our colleague Stephen Pillinger. When I started my robotic fellowship with Craig and Steve, this is one of my first robotic cases. It's a 66-year-old female with an MRI stage T2 N0 adenocarcinoma, 8 centimeters from the verge, no distant or nodal disease from staging scans, consented for robotic ultra-low anterior resection, marked with ICG as we tend to with a flexible SIG before the case. We've done the standard things. Splenic flexure has been mobilized. The tumor has been identified and a stapler was placed distal to the tumor without issue. The IMV and the IMV were taken to the origin, and we generally do, Steve generally does an intersided anastomosis. Couple of technical issues here, and it's, I think, quite impactful in this case. She's had a BMI of 40 with extremely fatty colon, making tissue handling difficult. And this led to a 6-hour operative time, which is about 3 hours longer or 3.5 hours longer than our median for an anterior section. Just going to play the video, and I've obviously selected little bits of this for this 4-minute video to keep to time. What I'm just showing you here is the dissection of the distal portion of the rectum in the right side of the pelvis. In a couple of seconds, we'll see the ICG flick on, just as an interesting part. So we use it often to mark the tumor as opposed to using spot. Just find it a bit easier to then trace where that is. So that'll show up in a second. As you can see, that's the distal portion of the rectum. And I just want to note how fatty the mesentery of that rectum looks. So as you can see here, I don't know if anyone can see my arrow, but posterolateral on the right, that's the tumor. And I've edited it out, but we very safely and very effectively got a stapler across that without a problem. So then the distal transection was reached. This was done after this was followed by taking the IMA high and taking the IMV and mobilizing the splenic flexure. That portion was very challenging. Again, if you can see the actual size of that colon. The mobilization was complete. And here we're just looking at the indocyanine green test that we do for every case before we make our proximal division, just to examine the health of the conduit. And very soon you'll see coming up the indocyanine green that we use. We're focusing on the area that we've marked. The ligature device has been placed underneath the bowel, and it will come up very shortly. Might just speed that along for time. As you can see, it starts to show up quite well. We'd like to pay attention to not only the intensity, but making sure that we can see the small vessels that you might have noticed there. And we were fairly happy with that particular anastomosis. So a linear stapler was then placed across where the ligature or vessel sealer device is. We then inserted an anvil using the robot to create an end-to-side anastomosis, with the spike of the anvil being placed in the anti-mesenteric side. That means there was a circular staple line and a linear staple line because it was an end-to-side anastomosis. This was then followed by what I thought was the most interesting part of this case when I reviewed the video, was the docking of the circular stapler to the anvil. And while this lady had a very large pelvis, I did notice that and I do remember struggling quite a bit. Steve took over for this portion and trying to actually dock the anvil to the circular stapler. And the reason that's happening, and you can see that it shouldn't be that difficult, is I think there was quite a bit of surrounding fat that actually made getting that sort of anvil nicely into the circular stapler quite difficult. And these were just some of the technical challenges that we faced in this particular case. And as you can see, it's quite a struggle. And we really was the mass of that colon and the way it fit into the pelvis. And really, we did talk about this recently, and Steve and I both think we probably should have reverted and done an end-to-end anastomosis, really. So I'm just going to cut the video off there. Thank you. So post-operatively, the patient recovers well, return of bowel function on day 2, histopathology, T2, N0, 20 lymph nodes, clear margins. She was discharged on day 4, which is about median day of discharge for us. On day 9, she returns to the emergency department with a CT showing a gas-containing collection in the right pelvis. We do a flexible sigmoidoscopy and notice the linear staple line in the corner has an obvious defect, not the actual circular anastomotic line. I have a picture of the circular anastomosis in a second. We also do a laparoscopy. We don't find significant contamination anywhere. We see an obvious inflammatory area in the right pelvis. And at the time, we made a decision that, in retrospect, probably wasn't a good one, not to defunction the patient, stick a drain in that pelvis. We attempted to control the defect in the linear staple line with clips. This was the circular staple line. When we went beyond it, we could see the linear staple line of the blind end had a little defect. We tried to control it with clips, and this was the cavity that we saw that we subsequently put a drain into. Day 11 to 20, the CRP on the day of the take back or the day after goes up to 380, which is concerning. It subsequently comes down to 80 on day 20 and then rises again to 150. We repeat the CT with rectal contrast, and this time we see a persistent right pelvic collection filled with contrast and some fecal material. So at this point, we admit defeat and do the sensible thing. Return for a washout, drainage, and lap ileostomy. The patient subsequently improved. The sepsis subsequently settled, and on day 30, the patient was discharged. Her ileostomy was actually just reversed about 4 weeks ago after having a normal flexible sigmoidoscopy and a normal gastrographic and contrast enema. And she was discharged about 3 weeks ago, and she hasn't had a problem. So we've been fairly happy with the progress. She actually got a scan before she left hospital just to be safe, just to make sure that leak wasn't still persistent. So the remit that we're given for this particular segment of the conference is what do you want to solve and overcome? And I just thought some interesting discussion points that we could cover. What was the cause of the leak? The high BMI, should we have defunctioned the patient? The use of the end-to-side anastomosis in that crowded pelvis, should we have abandoned it and gone for an end-to-end? I think in retrospect, that was probably a good decision. And is there any, and I couldn't find data on this, so I really appreciate feedback. Is there any limitations to detecting venous ischemia for indocyanine green? And as the other thing that's interesting to discuss, should we have defunctioned her at the first laparoscopy? To me, it seems like we probably should have. And we've been quite fortunate with her outcome in the end. And I think it's for that particular complication, for the linear staple line to have had a hole, was there in fact a role for the endovac? And I would actually welcome feedback on that. Just for the last 2 minutes, because I've got time, just some interesting discussion points. So should she have been defunctioned at the index operation? We do know obesity does lead to higher rectal anastomosis leak rates, 10.4%. Or it's about 2% higher in the Western population. If you plug it into our local Adelaide-based anastomotic leak calculator that was created for Australian patients, her leak rate was about 10%. But of course, we have to balance that with the fact that, as we all know, there are chapters upon chapters written about the management of a difficult stoma and the obese patient. This lady has large central obesity. The formation of a stoma wasn't easy, but fortunately, she did quite well with it. Can ICG reduce anastomotic leaks? Not sure what everyone's opinion is. I see someone shaking their head. But we do have some data suggesting that it possibly can. This is based on individual participant data analysis. So that's from 9 studies where the data was provided to the authors of this particular analysis, including 4 randomized control trials and several prospective trials. And it did actually show potentially it does reduce anastomotic leak rates. The crowded pelvis, welcome any feedback on this. I think this is quite an interesting, I wonder really whether potentially it's created tension or caused a bit of compression and venous ischemia in that linear staple line. And then anyone with experience in the use of the endosponge in a vac, that I think is a very interesting discussion point. Again, that leaking linear staple line corner, there has been some review articles now about the use of the Braun endosponge, which has about 11% failure rate, but they really struggle to work out size of defects or exactly what type of leaks they were discussing. And this was a very interesting article from Portugal, where they basically showed the progress of that a closure of a defect in a rectal anastomosis over 5 months. And they then used a bit of fibrin glue to close up the little defect that was remaining in the bottom right corner picture at the end of month 5. And that is it for me. Hopefully I've kept the time. I think I have. Thank you.
So thank you very much, Praveen. So I think we can move on to Q&A right now. Is that Joe? Right. Yes. So it's open to the floor for discussions, for comments. So any comments and questions from the panel? Now, my first question to you, Praveen, is what is your role in this case?
I was the fellow / I was using the console, but it was one of my first robotic cases with Steve, but I was there for the entire case. Yeah, I was getting mentored through robotic surgery at the time.
So the case was not done by you, right? But were you the?
It was partially done by me. It was part of my learning curve as a fellow.
All right, so part of the surgery was done by you. All right, okay, good. So there were a few questions in the Q&A. So asking whether you did air leak test and what happened to the donuts afterwards.
The donuts were intact. We send them off for analysis, and we do an air leak test. We actually do a colonoscopy at the end of every case to assess the anastomosis and also look for any bleeding. So the air leak test was negative. Okay, so you did an on-table colonoscopy as well. I see. All right. Sorry, that wasn't mentioned in the slides. Okay. Right. So what? So why do you say it's a venous ischemia? Why do you keep on saying venous? I was just, it was a general question. I mean, there was said other points of discussion, and I was just wondering, did anyone know whether ICG would examine arterial flow? And I just wondered, is there any possibility where I have read papers and data about venous ischemia causing a delayed leak that may not show up? I see someone else shaking their head. Does it in fact get picked up by ICG? I had tried to look this up and I couldn't find any answer. So I'm very interested in the panel's opinion or knowledge in the area. Well,
yeah, I remember, I think it was 2 years ago, William invited me to do a lecture on colorectal anastomosis. And I have shown that with ICG, we have not exact conclusion concerning the venous flow. And particularly in post-operative time, and we will have thrombosis of the venous network, particularly in obese patient with a narrow pelvis, with compression of the pelvis, and the flow will be very low and will fall, and the risk of thrombosis and ischemia, late ischemia. So we will not do the exact, I would say, information concerning the vascularization of the distal colon and anastomosis in the future. So I suppose in a huge obese patient as morbid obesity in this case, it is a main reason of the fistula, of the ischemia. I suppose the solution is difficult, and doing side to hand perhaps is more compression, because you will have more, as you said, more fat in the pelvis and more compression. And perhaps end-to-hand in this case, even if I do side-to-hand in the majority of cases, would be better.
That's great. You want to say something?
Yeah, I was just saying, I think the ICG in this case can be falsely reassuring because you do it before you do the circular staple line. And because the pelvis is that sort of obese and there's no room, you can't redo the ICG. So you could actually have an ischemic anastomosis and not be able to see it. Even though before your circular anastomosis, it looked fine.
And I wonder whether that's what's happened.
Well, I think that ICG probably cannot prevent the leakage on this particular case. And I perform ICG majority of my cases, but when do you perform ICG? I think is the key. I mean, you perform the ICG right away, right after your resection, or you wait for a while and then you perform ICG.
Right, 20 minutes.
Yeah, so I mean, I learned that from Leroy 2 years ago when he said so.
Yeah, it was a nice session. Yes, I remember.
So very good, thank you. So now, Praveen, can I ask you now, if you were to redo, I mean, if you have a chance to do this case again, would you do it differently? I mean, well, at least
I think I mean, again, so in discussion with the mentor that was training me, and we did the case together. We did discuss we probably should have done an end-to-end anastomosis, and we probably should have defunctioned her the first time. Yeah. I brought up the endosponge, but I've used an endosponge once, and I was just wondering again who's had experience with it, and in that sort of linear staple line that's sort of opened up, but not too much. Would it have been an effective choice as an alternative to a stoma, particularly as an alternative to a stoma? Defunctioning her, leaving drains in has worked very well. She's done well, but is there an alternative to giving that incredibly obese lady who's gotten away without a problem with her stoma to giving her stoma? And that's just the question I thought I'd pose to the floor.
It's a matter of pros and cons, but in this lady, I think it's difficult surgery, 6 hours surgery. All right, even though it's a lady, even though it's non-neoadjuvant, I think I still go for defunction. All right.
Yeah.
Actually, do you perform any reinforced suture to close the dog ear of the double stapling during the surgery?
Only if it seems concerning. I have to be honest, since I've started using the XI, I rarely find that to be a problem. But I have in the past, but I don't do it routinely.
Right. So sometimes there is a question, I think, just like in this case, actually in this case, do you have you find any problems during surgery? However, but the difficult anastomosis, if I can, I usually perform some reinforcement suture, especially the left side. Right side is rarely a problem, I think. The left side is usually the problem in my cases. So that's one of my comments in this case. Thank you.
Thank you. Yeah, good. We have a lot of comments from our experts. So it's time's up for our first presentation. So for the sake of the audience, please stay with us, and because you have to vote for your friends and then to see whether he or she can win the prize of the best presenter. So we now move on to the next presentation. Our next lead faculty will be Dr. Lai Jin Hong. Currently, he is a special surgeon in Singapore, and he owns a very big clinic in the middle of the city, and he's currently director of his clinic. I saw his Facebook. He has maybe around 10 beautiful nurses in his clinic working with him. So maybe Dr. Lai, it's your turn.
Thank you, Joe, for the introduction. I will have drinks after this once I can come up to Hong Kong. All right, I'd like to welcome all the audience to APELS and introduce our next trainee presenter. All right, I will call him our next surgeon. All right, Dr. Supratim Bhattacharya from India. He's a fellow from the Healthcare Global Cancer Center in Bangalore, India. And he will present to us some troubleshooting tips in his circular stapler misfire. I just want to let Dr. Supratim know we've got 10 minutes to present and then 5 minutes for the panelists discussion.
Sir.
Take it away, Dr. Supratim.
All right, sir.
Thank you.
Thank you, sir. Thank you, sir. So is my screen visible here?
You are sharing a screen, but not having your slides or video on it. Oh, yes, we can see. Good.
Visible, sir?
Yes, please proceed.
Right, sir. So this is a case of intraoperative management of end-to-end anastomotic stapler misfire. So my patient is a 65-year-old male patient with a good performance status. Came to us with a history of rectal bleed for past 2 months. Rectal examination, there was no abnormality. Colonoscopy was done that showed a growth at the rectosigmoid, which was about 20 centimeter from anal verge. Biopsy was well-differentiated adenosis. Serum C at this point of time was 8.2. So we routinely do a PET with CCD fusion for all our cases. Here we can see the growth, sigmoid colon, and approximately coming to the upper part of rectum. Also, we can see there's some stranding and lymph nodes as well. So we took the decision to do upfront resection of this growth with a plan for robotic anti-resection. So I would like to start my video. Here I will only show this pelvic part of the procedure. By this time, the specimen is already out. So here, as we can see, the stapler is fired. But unlike other cases, we're not being able to the stapler through rectal route. There was some hinge over there. We were not being able to understand what exactly is happening. And after that, we saw that there's a rent right over here. And we could see the stapler is coming out from there. And we saw that the rectal stump was disrupted there. We can see some loose stapler float. And although we checked the integrity of the staple, anvil was still fixed. So we planned to remove it off. And after that, we took the stapler back through the rectal route. By this time, this rectum was already deep into the pelvis. So the option of again putting an endostapler was not there. And as we can see, an important thing to see here is that this is a part where we are seeing the distal donut, and it is also fixed with the rectum itself. Our first robotic arm is the hot shear, and R2 is bipolar forceps. So with the help of R, we plan to resect out this donor first. We also have an assistant port to the right of patient, and we plan to take this donut through the assistant port itself. As you can see, although the division of rectum was high up in the upper rectum, junction of upper and mid rectum, and we also examined the specimen. It was appearing to be okay. So oncologically, we were sound till here. But we can see the staplers are floating here. So it would be a good decision to close this rectal stump with staple lines like this. So we just try to trim the staple line with hot shear and just take the bits of tissue through assistant port itself. As you can see, the rectal lumen is seen here, and there's no tumor left. After that, we started closing the rectal stump using 3O V-lock. We usually take 15 to 20 centimeter of length of V-lock. V-lock is, we usually use V-lock as because there's no chance that this stitches will come off the rectal stump, and it's much easier for the anastomosis purpose. So we use two layers here. First, we started from patient's left and we moved to patient's right. And after that, again, we reinforce that layer back from right to left. And it's important to make sure that taking any other tissue into a bite, since rectum is not there anymore, so planes are not very well defined here. There's always a chance that we may end up taking other structures here. Once it is done, we check the integrity of proximal stump. Anvil was snugly fit over there, and there was no abnormality with that. So once this anastomosis, again we start creating after this completion of stitches there, and the same stapler we use, and we make sure that there is no intervening any other tissue inside the anastomotic line. And after that, we do a leak test to confirm that anastomosis integrity is maintained. And we have a extremely high threshold for ileostomy, and we plan not to do an ileostomy for this patient. So we plan to put some reinforcement stitches over this anastomotic line again. So again, it was a two-layered of reinforcement stitches that we placed using V-lock again. And again, leak test was done, and we confirmed that there is no anastomotic leak. So we avoided ileostomy for this patient. So histology was well differentiated, no CA. I think the pathological stage was T2 N1B, and patient stayed in the hospital for another 6 days, and after uneventfully discharged the patient. Now he's on adjuvant chemotherapy. So learning from the case is that first we have to get the clicking sound of stapler while it is locked, because it's important to know the stapler is locked properly. Second is that when rectal stump is already this is an unusual complication, right? So when it happens, the chance of putting another row of endostapler through abdominal site is not that easy, because rectal stump is already retracted deep into the pelvis. And then we have multiple options of staplers, but it's always good that we use the same one which you usually use, because we are more comfortable with it. And robotic is an option here, because endo suturing with robotic is much easier as compared to lap. And also we have this 3D stable vision and everything. So that's an option. So from experience from our center, it's a tertiary cancer center we are in. So last 5 years, we have done about 356 cases, out of which robotic cases were more, 274, lab cases were less, and complication like post-operative bleed was found in about 2.5% of case, leak about 4%. Ileus was less in about 5% of cases. Open conversion in lab procedures, we usually see about 6%, but we still didn't have any conversion with robotic. Ileostomy threshold is very high. Usually we reserve ileostomy for ultra-low AR and ISR cases. Also in some obese male deep pelvis patients and those with comorbidities. And all. This case was the first case where we found a similar end-to-end stapler misfire. Coming to some article review, end-to-end stapler anastomosis misfire is a rare topic, and article support is also less. This is one article from way back in 2010, where they've seen that in about 350 colorectal cases, about 20% cases had technical errors, and they found out that preoperative RT, malnutrition, inflammation, steroid use, these are associated with more chance of anastomotic leak and all. So these patients had more chance of bleed, ileus, post-operative blood transfusion, open conversion, ileostomy and all. And they concluded by saying that when there's an abnormal feel of the staple line, or there is increased resistance while applying stapler, that may indicate that there is some abnormality with the firing of stapler. This another article was published late by 2021, and they included patients with left hemicolectomy, sigmoidectomy, and LAR patients. And they also found that those patients with male sex more than 75 years and with comorbidities, emergency procedures, these are associated with high chance of staple technical errors. This is one interesting paper which was published in 2020, and they compared manual stapler with power stapler, and they found that anastomotic leak rate is much less when power staplers are used. We also have some experience with this, but unfortunately we don't have statistics for that, so we really don't know at all it affects anastomotic outcome or not. Thank you.
Thank you, Dr. Supratim, for that presentation. I think I'll open the discussion to the floor, but I'm going to ask you a couple of questions first. Are you the
Thanks,
primary surgeon in this procedure?
Yes, sir. Yes, sir.
So you
I
make
was doing this, yeah, this procedure guidance of Dr. Chen.
So you were the primary
Jagannath,
surgeon,
but
primary surgeon in this procedure,
yes.
and you made most of the decisions.
Sir, actually, I thought it would be easier for us to do a suturing of the stump and then reapply the stapler, because firing a second row of endo stapler at this point was I was not very comfortable with it.
I've got 2 points for consideration. Number one, I think with the tumor at 20 cm, even with good adequate margins, your rectal stump should still be about 15 cm long, which makes it at above the peritoneal reflection. So I think the exposure from the robotic surgery, from what I could see, may not have been as adequate as what it could be for you to troubleshoot the rectal stump. Secondly, I want to ask whether you have considered, once that it opened up, instead of trying to suture, I would say across the whole stump, perhaps to consider a distal purse string. That would be very nice to have a nice purse string below, and then apply the something for you to consider. You know, I mean, applying staples across an open stump sometimes may be challenging, but a purse string with a robotic device, something for you to consider. The last one I wanted to ask was, this one you might want to tell me, who does these distal stapling for you in your institution?
Usually I have a bedside, sir, and she's a trainee here, so she does it for me.
So, and I would say that I think you were saying that you're not sure what's the cause, but having used the EEA stapler so many years and also different brands, it appears that the stapler was attempted to be pulled before the stapler has been opened enough after the anastomosis, and that's caused the first opening, and thereafter the further manipulation ripped the whole anastomosis apart. So I think that is it may not have been a misfire from the stapler point of view. That means it was not a stapler malfunction, but it may have been a personnel training issue with using the EA stapler.
Could be, sir, but we're not sure, because we are using the same thing for all these things, sir. EA stapler firing, and then every other case we didn't have any such complication like this. This particular case had this thing, so we use the standard procedures of applying stapler. I don't know what happened, means what went wrong with this case.
Any answer to the using a distal purse string? Did you thought about that when you were doing it, using a distal purse string to reapply the stapler?
So I was not very comfortable with using a purse string. Of course, that's an option, yeah. But then maybe at that point of time, I found it much easier to do just continuous stitches with below.
The other faculties, questions from?
Thanks, Lai. No, can I just ask? I might have missed from your video. What did you use for transection of the rectum? Is it endo stapler or what?
So we use endo stapler, articulating one. So in this case, we use 2 staplers.
Robotic.
Yes, sir. not robotic, sir. This is one SI we use, sir. So there is no stapler with this. So we put the stapler through assistant port, standard lap endo GIS stapler. So in this case, we use one 60 blue and one 45 blue for distal transection of rectum.
So you still need 2 staplers, right?
2 staplers, yes, sir.
Right.
And blue is enough for thickness because it's in obese patient.
So we usually cut this mesorectum until we see the rectal serosa, sir. After that only we place stapler.
Yeah, no.
So usually go up.
Which level from the anal merge?
So this patient actually had one upper rectal transection because the growth was about into yes, sir. Rectosigmoid growth it was. So we mobilized it for like 3 or 4 centimeters underneath the tumor. After that, we plan to resect the rectal stump.
Craig?
I'd agree with your comments about a purse string. My worry would be if you closed it with a suture in a linear fashion and you didn't include all the staple line in your circular anastomosis, you may end up with a bit of a hole somewhere. Also, the staples appeared to be fully formed. And with the EEA, normally the anvil flips when you take it out, so I'm not quite sure what happened with that. Yeah.
So even with
but yeah, I've had the same thing.
We're not sure about this. This is happening. Yeah. We didn't face any similar cases earlier, so we're not sure. Something might have gone wrong with this case.
But we have seen the staples in the field not close.
Yes,
so
yes, sir.
It seems they were pushed without anvil in front.
So actually, when we evaluated, the anvil was snugly fit into the stapler. And also we made sure that this green line is there, and after that we fired, we held, we did everything which is done for all our cases. But I'm not quite sure what exactly happened to this case, and we ended up like this.
I've got a comment. I mean, since coming to private practice, I do all the stapling myself below because that's the most important part of the surgery. You can do everything on the top. Just before you can train somebody to hold the anvil with the anvil backcock at the top. You come down and do the stapling yourself, or you got to train a trainee to be trust a trainee who is very well trained to do that for you. I mean, that's my comment to ensure that this part of the surgery goes well. So that's for my comment to Dr. Supratim.
Yes.
Can I comment a little bit on? I think the part is that the trimming of the distal part and the mesorectum. I think you should be clearly see where you're going to transect and where you're going to. If you leave a lot of fat, like I see on a video, I mean, you have some trouble with yourself. So my point is, you got to trim the mesorectum clearly, so when you place the stapling, it'll be nice and easy. So if you leave a lot of fat there, I mean, something's going to go wrong.
I agree completely with all the comment of experts from William and Lei. And I would say in 90% of cases, misfiring of stapling is due to human.
Okay, and thank you so much. Yeah,
it's true when we give the possibility to the assistant to do his first stapling, it is important to help him and to be close to him to explain all the detail and the feeling, the title feeling of the anastomosis.
Thank you. I
Yes,
think
sir.
time is up. We
Yeah,
pass
thank
to
you.
Joe.
Yeah, thank you.
Thank you so much,
Dr.
sir.
Lai.
It's
Thank you.
Honored to
Yeah.
Thank you, sir. Thank you, sir. Thank you so much.
Yeah. So we'll move to the next presentation. First, again, I would like to introduce our panelists, lead faculty, Professor Craig Lynch, a robotic colorectal surgeon in Sydney, Australia, and also clinical associate professor in Australian National University, Sydney. So Craig, it's your turn.
Thanks, Joe. So the next presenter is Dr. Jung-Hoon Bae from Korea, and he's a clinical practical assistant professor in the Division of Colorectal Surgery in Seoul at St Mary's Hospital College of Medicine. And he's going to be talking about transverse colectomy with both flexure mobilization. First approach. Thank you.
Thanks for a kind introduction. I'm honored to present at this conference. Today, I would like to introduce my first case of laparoscopic transverse colectomy with both flexure mobilization first approach. I'm Jung-Hoon Bae from Korea. Transverse colectomy is known as most technically demanding procedure among colon cancer surgeries. There are several reasons for this. First, transverse colon cancer, especially mid-transverse colon cancer, is rare, less than 5%. Second, vascular anatomy around the mid-colic artery origin site is complicated and variation is common. Moreover, post-flexure takedown is mandatory procedure in transverse colectomy. For these reasons, transverse colectomy has not yet been standardized until now. The patient I'm going to show you today was a 57-year-old female. She was diagnosed with adenocarcinoma in mid-transverse colon. On abdominal CT, the clinical stage was T2 N0 M0, which was considered early cancer. Therefore, we preoperatively performed colonoscopic tattoo using indocyanine green and clipping for marking of cancer. Under general anesthesia, I used 5-trocar. Before watching the video, I would like to inform you that I'm a very inexperienced surgeon. I have less than 10 experiences with laparoscopic distal lymphadenectomy in colorectal cancer. And the laparoscopic T colectomy I will show you now is my first case. Now let's see the operation video. First, I identified the tumor location where we performed colonoscopic tattoo before the surgery. And marking, the dissection was started at ileocecal peritoneal fold. I identified white line of short fascia and right mesocolon was dissected from retroperitoneum. In this procedure, I tried to do traction and counter traction. The mesocolon was treated upwards using my assist port, and the retroperitoneum was counter-tracted downwards with my left hand to create a clear dissection plane. At this time, the operator and scopist were located on the left side of the patient. We continued dissection until reach hepatic flexure. And the duodenum circumposition and pancreas head was separated from mesocolon, from right mesocolon. And the difficult part, traction and counter traction, I changed the energy device, and pancreas head was dissected from right mesocolon. Dissection. Then I dissected ascending colon lateral attachment and right gastrocolic ligament was divided like this. Right mesocolon was fully mobilized. And then I identified inferior mesenteric vein and dissected below IMV. And then I focused on the pancreas I divided the transverse major colon from inferior border of the pancreas through inferior approach. I continued dissection until reach lesser sac and could enter the lesser sac. And the dissection continued to separate completely between pancreas and transverse major colon. At this time, I moved on the right side of the patients, and I identified the tooth fascia. The left major colon was dissected from retroperitoneum, also using the technique of traction and counter traction. Then we dissect descending colon lateral attachment, making window for separation, and the splenic flexure mobilization continued. And then I started lymph node dissection. ICG was injected by IV route. At this time, operator moved to left side of the patient again. The blood vessel shown on the screen was dissected, thinking that it was the root of the midcoronary artery. However, it was actually the left branch of the midcoronary artery, not the root. Then we dissected around the midcoronary artery. The root of the midcoronary artery was dissected and ligated at its origin site, and it was cut by NS device. I more dissected around the root of the midcoronary artery. The omentum was divided along the lower margin of gastroepiploic vessels. And the transverse mesocolon was fully mobilized. Extracorporeal anastomosis was performed. Before making anastomosis, perfusion status was checked by ICG. This is the final surgical view. There is an anastomosis site and the SMV, pancreas head, duodenum circumposition, and the pancreas was completely separated from transverse colon. There was no intraoperative complications. The operation time was 290 minutes and estimated blood loss was 200 cc. Post-operative management was performed by enhanced recovery after surgery protocol, and the patient was discharged on the fourth post-operative day without any complication. There were no lymph node metastases among 21 harvested lymph nodes. The final pathology was T3, N0, M0. I have 3 discussion points. First, for a beginner like me, who does not have much experience in laparoscopic surgery, the most difficult thing compared to the open surgery is the traction. The traction is convenient. Making a surgical view was difficult for me. Second, both flexure mobilization was relatively smooth, but the dissection of the midcoronary artery was not easy. Is there any surgical tip of just the midcoronary artery dissection in transverse colectomy? I need the standardization of the procedure. Thanks for attention.
Great stuff. Thanks for that. It was nice to see your own case being done. That's good to see. Can I just clarify, did you end up doing an ileocolic anastomosis, or did you anastomose the right colon?
Yeah, I did.
What was the anastomosis? Was it an ileocolic anastomosis?
Right colectomy, you mean?
Yeah, did you leave the right colon?
I did anastomosis between the distal ascending colon and the proximal descending colon.
Right. Given you'd mobilized the entire right colon, did you think about doing an extended right hemicolectomy and doing an ileocolic anastomosis?
I think the right colectomy is another option, but
it may have helped your approach to the middle colic vessels also.
Yeah. I'm sorry.
Approaching the middle colic vessels once you've divided the ileocolic may also have been a bit easier.
Yeah. Sorry for my short English. I'm very sorry. Yeah.
I mean, normally you'd think about having good reach from where the right colon is across to where the left colon is. Would be another reason why often an ileocolic might fit better.
I think the right colon mobilization is first, the reason, you mean?
Yeah.
Maybe the right colon is fully mobilized is much easier for me. And the left colon is fully mobilization of left colon is no need for transverse colectomy, I think.
What sort of orientation did you have the patient in for most of this? Were they mostly head up, or did you move around considering where you were placing, where you were operating at the time?
Yeah, pardon?
How did you have the patient positioned?
Position, yeah. The Trendelenburg, and when I dissected the right vessel colon, the left side down, and when I dissected the left colon, right side down, and the dividing of the omentum, the head up, more plane. Yeah.
Good. It's nice to have that sort of structure when you're doing it. Has any other panels got any other questions?
Dr. Bay, thank you for the nice video. I wanted to ask you if you had thought of doing the vessels, dissecting the vessels first before the flexures, because you had difficulty getting to the vessels. I would think that if you had mobilized the flexures, it may make it a little bit more cumbersome to get to the vessels rather than to approach the vessels first.
You mean that how I think the vessels first approach?
Yes.
In my opinion, if I dissected vessels approach, I think the finding of the origin site of the midcoronary artery is much difficult because of the retroperitoneum attachment of the transverse colon. So I think the midcoronary artery dissection is more difficult.
Can I add a little bit comment? I think if I would stand in the between the leg of the patient if I do perform a T colectomy, and attacking the vessel relatively easy if you can find a surgical trunk. So I would attack the middle colic artery first, and then do the bilateral flexion mobilization. I do agree with your with the way you operate with by mobilizing both flexure and then just reset the T colon. And this I do it only for the tumor just sit right in the middle of the T colon. Then I'll perform a T colectomy the way you were performing. And in addition, I'll perform end-to-end staple anastomosis for this patient. Maybe Gerald want to add more on my comment.
Thank you.
Nice comment, William. I agree. It's a nice presentation, but it's very long surgical procedure, 5 hours. Yeah. So this is very, very long for me. You can do shorter if you do right colectomy, extend on the left, but probably in early case, early cancer, I will do as proposed, William. And you said at the end of the procedure, you had a big problem for doing traction, counter-traction. It is, in my opinion, because you did lateral mobilization first. I do personally staying between the leg of the patient, as always I do, as is doing also William. I do a medial posterior approach, and I'm doing exposure retracting the transverse column cephalad. And I do all the posterior fraying of the attachment of the transverse mesocolon, and it's not, there is no change for the traction, counter-traction, because there is always a traction. So we win a lot of time. So surgical strategy is really, really important. And I did movie, you can see on YouTube, concerning the transverse colectomy for cancer. So
Thanks
this is
comment.
my comment, but I agree with William.
Okay, very good. Any other questions or queries? Okay. What do you think you could have done better with your case?
Yeah.
What do you think you could have done better?
Better. How could you done better in the next case?
I think I need more surgical experience because of this year is my first year as a operator. But I attended the operation as scopist for 3 years, about 500 cases in same operation. So I think the more experience is needed.
Okay, I think we have to move on to the next presentation. Thank you so much. Thank you for the great lynch. Professor Lee. Professor Lee?
Yes, I'm here.
Yeah, it's now your turn to introduce our next speaker.
Let me introduce Dr. Liu Jianwen. He's from China. He's associate consultant at the University of Hong Kong, Shenzhen Hospital, Shenzhen. So he's working with Dr. Joe Fan. I think today he will present the intraoperative complication of natural orifice specimen extraction surgery. Dr. Liu Jianwen, please.
Thank you for your introduction. Dear professors, dear doctors, is glad to share our intraoperative complication of nosis. So what is nosis? Nosis is so-called natural orifice specimen extraction surgery. We usually use vagina or rectum to take out the specimen of the abdomen. It has a less pain and less scar. There are several pictures of the incision. Here I will present two cases of this intraoperative complication. The first case is a 59-year-old lady. She was diagnosed with carcinoma of sigmoid colon. The clinical stage is T3 and 0. We preserved the left colic artery and dissected the 253 group lymphoma node.
Oh.
Then we can see the left colic artery here, and then we mobilize the splenic flexure. Then we transect the distal colon and the proximal colon. We use a bag and take the specimen out of the abdomen where they through the vagina. When we pull the colon out of the vagina, we find the IMA broke off, and a lot of fresh blood came out. Then we use a clamp and then use a clip to ligate the IMA and ligate the distal IMA2. Then we lavage the pelvis and take the colon out of the vagina successfully. And the second case is also sigmoid colon, carcinoma of sigmoid colon. It's 53 female. The clinical stage is also T3 N0 M0. We also preserve the left colic artery and dissect the 253 group lymph node. As the sigmoid colon is very long, so we thought the colon is long enough to be taken out, but after we transect the distal and the proximal colon, the specimen was taken out. When we pulled the colon out of the vagina, we found that it is not long enough to be pulled out. So we decided to do the post-treating intraabdominally. Then we open the stump and make the post-treating like this. And then put the envelope into the colon. After finished, we check the we checked it. This area is not very good, so we add the suture here. Then we check it. Seems good. Then we do the anastomosis. We can find that this area and this area, this rosa is not is incomplete, and then we check the donut is not a little incomplete. We try to sorry. We try to make a bearing of this anastomosis, but we think there was a high risk of a leakage, so we decide to redo the anastomosis. Then we transect below the anastomosis and then make a small incision. We transect the rectum below the anastomosis. Then we make a small incision and take it out. We can see there is not the serosa is not incomplete. So in 2013, there is a cadaveric study showed that high ligation and of IMV plus splenic flexure mobilized has the most length of colon. So my question is it necessary of preserving the left colic artery? At the same time, 253 group lymphoma node dissection is necessary for sigmoid cancer. And conclusion, it's very important in surgery to make a decision in surgery, and it need a longer length of a colon in nosis surgery, both vessel mesentery and the colon. Thank you.
Thank you for the nice presentation, Dr. Liu Jianwen. So actually, for the lengthening of the colon after mobilization of the splenic fracture, if there is an intact marginal vessel, you don't have to preserve left colic artery every time. So what do you think about that? So you don't have to try to preserve the left colic, ascending branch of left colic, if you need the longer length of the colon.
Yes, if they actually the colon is usually long enough to be taken out. Usually the mesange and the vessel is not long enough to be taken out. So if it is not long enough, I think the IMV and IMA should be ligate in the on the root. So-called high ligation.
Mm-hmm. Right.
Yeah.
Any other comment from the panelist?
May I do comment?
Oh, sure. Please go ahead, Dr. Rua.
Very nice lectures. I love, as you know, probably, I'm a fan of nose procedure. It's a term introduced by our friend Palani Velu. I did a chapter of a book of your colleague, Chinese colleague, that is Suk-Hwan Wang, that did a fabulous book on all the nose procedure in cancer and not only. And what you have shown is interesting because we understand that we have to do large mobilization to have a tension-free anastomosis. In the first case, you try to pull the colon to introduce the anvil through, after pulling the colon through the vagina, if I have well understood. And it was impossible because not enough length. It is why I have introduced a modified Franklin technique. We pull the colon with the tumor outside, and above the tumor, we introduce the anvil through a small colotomy, and we divide the colon with a stapler inside the abdominal cavity. The anvil is attached to a sutures, and we will do the exteriorization of the anvil in the closed segment of the proximal colon. And this will avoid to pull the colon and to do a larger mobilization of the left colon. And this will be safer, avoiding a traction on the colon. The second case is a technique proposed by Maurice Franklin in '91, so it's not recent. And this technique, why he proposed it? Because we have no linear stapler at this moment. And he was introducing the anvil in the proximal colon and doing the anastomosis like this. Concerning the mobilization, I think in Asia, it is less necessary doing large mobilization as we do in our country, in States or Europe. So this is what I wanted to do as comment.
Thank you very much. So
some comments I would like to make following Leroy, because I've done many nose operations. And in fact, I just did one this morning. I rarely pull out all the colons outside. and then inserting embryo. I'll do the embryo insertion inside the abdomen, and I like to perform more of a single stapling operation for nose. And if I perform an anterior section or low anterior section, I will not bring my spaceman through vaginal, because if that's only if you have a leakage, you might have a chance of rectal vaginal fistula. So I only bring my spaceman through a vaginal on I will perform on probably colon surgery, colonic surgery, especially right hemicolectomy or left hemicolectomy. So mobilization of spleen flexure for your case 2, I think would be, instead of doing the procedure, then I will mobilize the spleen flexure to make to elongate the length of the colon. So I think mobilization of the spleen flexure is mandatory. For my nose, I will perform almost always mobilization of spleen flexure when I perform nose procedure operation.
Thank you. So do we have any questions from the audience? So right now we have more than 100 of attendance. So Professor Dr. Joe Fan.
Yes.
So I think it's time. It's time. Yeah. So now the time to conclusion. So I'd like to invite Mr. Michael Lee for the closing comment.
Well, Professor Lee, before we close the session,
I see. Okay.
Yeah, we'd like to ask our audience to vote for the first presenter. Yeah.
Yes, exactly. So this is the competition session among the trainees. So would you please vote one doctor who impressed you so much and who will be the winner?
Or he may be your best friend, good friend, or from your institution. That's how we encourage the participation from various countries and units.
Yes.
Meanwhile, our faculties are giving the score because the prize will compose of 2 components. One is from the voting from the audience. The other part is from our faculties and our experts. So we'll have the final score after we all voted. And then probably Kadara will give us a signal when they finish the scoring and calculation.
So how many votes do we have right now?
Sorry?
How many votes do we have right now?
I don't think we have any real-time calculation, but we'll have to do it.
I think we're 125 participants currently registered on the active.
Right.
So, but then some of the 125 are the faculty and the participant. So we have to see how many of the actual participant of the workshop would vote for our speaker.
Yeah.
Shall we take this opportunity to do a group photo?
Yeah, sure.
Oh, sure.
Yes.
Dr. Liu Jianwen, yeah, please turn on the video, okay?
Okay, yes, coming.
Okay.
Yes.
Say
So
cheese.
smile, please. Yes. Thank you so much. Yeah. That's great. Thank you. I think I've got a very good screen cap.
Good.
Yeah, while we are waiting for the result, maybe we can now invite Professor Michael Lee, our chairman of APELS Society, to give us a final comment and also some feedback and some suggestion to this webinar. Professor Michael Lee.
Thank you. And first of all, I'd like to thank all the participating faculty members, the chairmen and speaker for excellent session of lectures in the afternoon. I also would like to thank the participants for our presentation, the 4 excellent speakers who've all put in effort to do this presentation. I think the voting is going to be very fine for whoever gets the prize. APELS first workshop this year, due to the pandemic, is still virtual webinar. But as you can see, there are no lack of enthusiasm from learning. We have at one stage 133 participants active, and now we've got 120 still on the screen. I hope with the ebbing of the pandemic, latter part of this year, we'll be able to resume our previous APELS workshop. If that's the case, we will have a hands-on workshop in the TTEC in the latter part of the year, and I would get all the faculty to be present for the teaching. We haven't met for a long time, and it's about time. And I thank you all for being here today. And I'm just waiting for the result to come through to announce the winner.
Yeah, thank you, Professor Lee. And it's a good platform for us to know each other. And also, for example, if any of our trainees are particularly impressed by particular faculties or the presentation, their surgical skills, and so on, maybe it's a good platform for you to contact your trainer and supervisor so that you can liaise with them to have a further overseas training workshop, attending the workshop from their unit, which probably, firstly, as mentioned, later this year or maybe sometime early next year will be the time that we can resume our physical meeting and training.
Sure. Dr. Zhou, why don't you introduce the next webinar to the audience?
The next webinar
is it June?
Yeah.
The Karen.
We need Karen, yeah.
Karen Kedora. Is it June? I cannot remember exactly.
We have a multi-center hybrid workshops, upper GI, which is going to happen around May or June, but we still haven't finalized the date, as we do have the hands-on sections, and we do have some selected countries joining this time. So if you're really interested in joining and in your respective country, please do actively watch out our social media platforms. But even if you couldn't participate the hands-on sections, we also would have a webinar, which is like this one, open to all, and all the other countries will have an opportunity to participate and learn from our faculties.
Yes, so last year, August 15th, so we had a successful live webinar, live hands-on conference by the APELS. So this time will be the upper GI multinational webinar-based live demonstration, right?
Yes. Yeah, this is a pioneer training activities. I think Mr. Lee also shared the learnings during ELSA last year as well. So I think it's something that moving forward, we can learn from the new technology, how we can utilize the internet and become better at teaching and educations.
Well, may I remind the faculties to have a look at the group chat and then have the final decision on the winner of today's webinar. And meanwhile, I will give you some more information on our previous kind of hybrid training. Because of the physical limitation, we can't travel to other countries. So that's why we utilize a different animal laboratory in different regions, like in Thailand, in Korea, Hong Kong, to organize simultaneous animal training in different centers in the same time. So that will simulate our previous APELS animal training. But of course, that may not be the best option, but this is the only option that we have for the time being. And hopefully we will have the real physical meeting coming soon. But for those who are interested in our physical meeting and also hybrid meeting webinar, please stay tuned in the YouTube channel, Facebook, and also the LinkedIn for further information.
Okay, do we have a result of the voting?
We're still waiting for the final decision because it's the votes and very, very, very close.
Yeah, we are reaching the final verdict. Just hold on for a second. So I think this is the first time that APELS issuing a prize to our wonderful presenter, and we really hopefully this will encourage more engagement from our community of APELS.
And also we shall invite our previous presenter in the webinar to attend our physical meeting in coming future. So that will be they will be our VIP in the coming workshop and also the physical meetings.
Sure.
So faculties, please kindly vote, have the final verdict and final decision on the winner. It's very close.
So just close the voting right now and then declare the final winner.
Yes.
Yeah, we have closed the vote already. Yeah.
Yeah, we closed the vote already, and we're sending the final verdict to Mr. Lee, and he will make the announcement soon.
For our P.
Okay, I've got the result, and can I announce it now?
Yeah, sure, Ms. Lee, please.
The winner of this presentation today has gone to Dr. Liu Jianwen from China.
Oh, congratulations.
Congratulations, Dr. Liu.
Thank you. Thank you for all.
Okay, thank you, Professor Lee, and congratulate Dr. Liu. And also we had a very high quality presentation from our trainees and also from our speakers.
Well, thank you all for attending APELS this time. Thank you.
Then thank this webinar and
have a good evening.
Thank you everyone.
Yeah, thank you so much. Okay, bye-bye.
Bye.
Thank you very much. Bye-bye.
Bye.